Hello, and welcome to the fourth webinar of NASTAD's Hepatitis Testing Partnership titled Public Health Detailing as a Strategy to Increase Hepatitis Testing. My name is Alyssa Kitliff, and I'm a manager in NASTAD's Hepatitis program, and I am the main point of contact for this group. Okay, sorry, I'm having a little delay on my computer. So for those of you who are unfamiliar with the Hepatitis Testing Partnership, NASTAD convenes this coalition of stakeholders, including public health, community-based organizations, academic partners, and others who are engaged in hepatitis testing or should be engaged in testing. And this is a group that convenes via a listserv. We have a Google group and also quarterly webinars to share best practices, lessons learned, and resources related to hepatitis testing. And before we get started today, I'm just going to talk a little bit about housekeeping items. So all of the webinars that we have for the Hepatitis Testing Partnership, including this one, are recorded, and the slides and the recording are both made available on the Hepatitis Testing Partnership page, usually within the week of the webinar, and I will share a link to that page in the chat box shortly. And we generally save questions until the end of the presentation, but if you have anything that comes up throughout the webinar or you want to put out some questions to be addressed as we open it up to Q&A, feel free to include those at any time throughout the chat box. And if you have any more administrative questions or technical assistance needs, you can always type that into the chat box as well. So today, I'm really excited. We're joined by three excellent speakers to talk a little bit about public health detailing and how it can be used to increase hepatitis testing. Our speakers will also share what resources are available related to public health detailing and provide examples of what the strategy looks like at the state and local level. So today, first we'll hear from Gretchen Weiss, who is the Director of HIV, STI, and Viral Hepatitis at the National Association of County and City Health Officials, or NACCHO. And after we hear from Gretchen, we'll hear from Nicole Dronin, an Infectious Disease Business Development Specialist at the Washington State Department of Health, and Jesse Schwartz, the Clinical Coordinator in the Viral Hepatitis Program in the New York City Department of Health. And as I mentioned, we'll have time at the end for Q&A. I'm aiming for about 15 to 20 minutes. And if there's anything that doesn't get addressed during that time, we will follow up and make sure your questions are answered. So I'm going to kick it over to Gretchen to get us started today. Welcome, Gretchen.
Great. Thank you, Alyssa, and thank you, NASTAD, for inviting me to participate in this webinar. Health departments play a key role in engaging and educating community providers about recommended clinical preventive services, chronic disease management, and other important public health topics. And public health detailing is an effective strategy for provider education. I wanted to note that I first became aware of public health detailing in 2012 when NACCHO included the City of Milwaukee's detailing efforts to promote expedited partner therapy in a toolkit we were developing at the time. Since then, we have worked to highlight the model, identify and share best practices, and develop resources to support local health department detailing efforts. Today, I'm going to provide a brief overview of public health detailing and NACCHO's Hepatitis C Public Health Detailing Kit, which you'll also hear more about from Nicole, as Washington State is using it to support their detailing efforts. I also want to give a shout out to Jesse, as New York City's public health detailing program has served as a great guide to NACCHO and many health departments. In 2015, we featured a story about New York City's PrEP detailing efforts in our PrEP story bank. So very excited to be presenting with Nicole and Jesse. Next slide, Alyssa. So what exactly is public health detailing? It's a strategy to educate providers and deliver key public health messages using tailored and brief visits and sharing tools and resources to support the uptake of clinical recommendations and best practices. It is sometimes referred to as academic detailing, and some of you may be familiar with the model, as it is a well-known marketing strategy used by the pharmaceutical industry. So the goal of detailing is to increase provider capacity to meet patient and community needs through the delivery of necessary clinical and preventive services. And thank you in part to New York City, we have data to show that public health detailing works. Healthcare providers and office staff have been receptive to detailing efforts, and providers report greater adherence to clinical practice guidelines and wide distribution of patient-directed educational resources following detailing visits. Detailing also supports the development of relationships between the health department and community providers. It is an opportunity for the two entities to connect, to hear from each other, and to open the door to future engagement. So detailing is not just a one-way communication from the health department to the provider, but also an opportunity for the health department to learn from its community providers. Next slide. There are a few key components of public health detailing. I'm going to say a thing or two about each of those that are listed here, recognizing that Nicole and Jesse will be sharing related information in their presentations. So detailing visits are, of course, at the heart of the detailing model, and many of the components below address what goes into preparing for detailing visits. There is the actual identification of the practices or providers that you are going to visit. The focus of public health detailing has been on primary care providers. However, depending on the topic, other providers may be targeted. In addition to the types of providers you're going to look at to focus your detailing efforts on, you'll also want to be strategic about which practices and providers you reach out to, especially if resources are limited and you can only get to so many offices. You want to be strategic about those with an eye to thinking about high need areas, underserved communities, and where you see the greatest health disparities. So detailing visits typically include a brief slide presentation on the topic of focus. And these presentations, of course, include critical information about what you are there to discuss, such as hepatitis C testing. And they really are most effective when they are tailored to the provider's interests and needs. So when you include local data about their patient population and disease trends, and really tie the information that you're presenting and the recommendations that you're making to the individuals that they are seeing. Putting together kits or leave behind materials is also an important component of public health detailing. And these materials, they should include information to support uptake of the practices recommended during the presentation. So resources and materials to support the providers put into place the recommendations that you've shared with them, as well as materials that they can distribute to their patients for education purposes. It is very important to think about the training of the individuals, whether they be health department staff or representatives of the health department going out and doing the detailing visits, thinking about communication skills and ensuring competency with the topics of focus. Follow-up visits can also be a key component of public health detailing. So beyond that initial visit, whether it be a phone call or another in-person visit with the practice, this is an important opportunity to reinforce key messages, follow up on progress that they've made, continue to develop the relationship, and potentially answer questions or help troubleshoot particular issues. And then lastly, evaluation to assess the impact of your detailing efforts and identify areas for improvement. Next slide, Alyssa. Thank you. So now to turn to NACCHO's detailing kit. Given the changes in the hepatitis C field over the past 5 years or so, there is a recognized need across the board for increased education and capacity building, with community providers being a priority focus for these efforts. With that in mind, and recognizing that health departments are uniquely positioned to engage providers, NACCHO developed a hepatitis C public health detailing kit. We wanted to encourage local providers local health departments to engage community providers, to consider detailing as a means of doing so, and to provide tools and resources to establish their detailing efforts. So the kit is available online, and it includes a user's guide, tools for healthcare provider education, leave behind materials focused on the provider, and leave behind materials focused on patient education. Next slide. So now I'm just going to take you through a couple of screenshots from the website of the detailing kit. So here we have our landing page, and I'll just focus for a moment on the user's guide, which includes additional information about public health detailing, really giving an overview of what it is and linking to some publications and examples from health departments for additional information. We also include descriptions of all the tools included in our detailing kit and their intended use, and then some key messages to consider incorporating into your hepatitis detailing effort. Next slide. So we put together 3 documents to conduct education of providers. And all of these documents are completely customizable, available in PowerPoint and Word formats. The first 2 are really the same, just in 2 different versions, with the second being completely unformatted. And this is a template already populated with some information we would recommend including in the presentation you would give during a visit. So there's information about hepatitis testing, about hepatitis treatment, linkage to care, information about national data and trends in hepatitis C, and also some specific placeholders where we make recommendations for key places where you want to consider including local or state data to tie the information to the community that the provider is serving. We also have a one-pager. This is something that can be included in the leave behind materials, and it includes some of the key messages directed at the provider, what the provider can do to increase hepatitis C testing and linkage to care, as well as some suggested readings and links to tools and resources. There's space here to put your health department's logo and to add additional tools and resources and contact information so you can really tailor it to your jurisdiction. And then lastly, we also included a Dear Colleague letter. This is not necessarily a core component of public health detailing. This can be a letter that your health department sends out to all providers in the jurisdiction, or messages that can be included in other communication to healthcare providers. And it's really to increase awareness of some of the key issues related to hepatitis C, to encourage providers to take action, and to let them know where they can find out more. This could also be something that you send out prior to launching your detailing program to let providers know that you'll be reaching out to schedule visits. Next slide, please. So then very quickly, this slide includes a list of suggested tools and resources focused on providers. And next slide, Alyssa. And this page is suggested tools and resources to include in the leave behind materials focused on patient education. And there really is an incredible amount of information out there. We selected what we thought were some of the key pieces of information you would want to include in a leave behind packet, but this is by no means exhaustive. So encourage you to think about other tools and resources that your health department or other community partners may have developed, but hopefully this provides a helpful starting point to think about what you would want to share with providers in the leave behind material. And next slide. So just want to thank you all for your attention and interest in this issue. It's really exciting to see how many folks tuned in today. I do also want to give a shout out to an ad hoc work group that NACCHO convened of health departments to provide guidance and input on the development of this toolkit. They are all individually named in the user's guide, so I encourage you to check that out. I've got my contact information here, a link to the detailing kit, and I've also included a link to an educational series, an online educational series that NACCHO developed about hepatitis C for local health departments. So encourage you to check that out, and look forward to the other presentations and the Q&A period. Thanks, Melissa.
Thanks so much, Gretchen, for that overview of detailing and NACCHO's detailing kit, as well as additional information about the educational series and what resources are available. That was a great way to start, and I'm going to turn it over to Nicole to share with us what Washington State is thinking about doing with these resources and how they're going to integrate them into their provider education and outreach efforts.
All right, thank you so much, Alyssa. I also wanted to just say thank you quickly to NASTAD for inviting me to speak today. As Alyssa stated, I am a business development specialist within the infectious disease prevention section in the Office of Infectious Disease at the Washington State Department of Health. My role as a business development specialist is to work with the health systems, payers, and providers to advance and integrate infectious disease priorities through policy development, relationship building, health education, and also resource alignment. Next slide. And as you know, a disclosure, we have no relevant commercial interest to disclose. Next slide, Alyssa. All right, so part of the reason why I'm spending the next few slides providing past provider outreach efforts is because it will help provide a context on why we're so excited about the NACCHO Public Health Detailing Kit. In 2016, Washington State was part of an NASTAD grant to do an EPI profile for the Washington State for hepatitis C. Once the profile was complete, part of our dissemination plan was to go out on an EPI roadshow and talk with providers and administrators about the hepatitis burden in their jurisdiction. Next slide. So as a result of the EPI profile, a team from our infectious disease prevention section went out and conducted 21 presentations throughout the state. We focused on regional distribution. So we reached over 400 providers and hospital administrators and other stakeholders in each region. When we went out on this EPI roadshow, we collected information back from the providers after each presentation on the questions or concerns they had around hepatitis C. Next slide. So when we went out on these roadshows, we presented data in each area of the state and it was relevant to their audience. The team explained the burden of disease in each jurisdiction, new testing recommendations, new less invasive treatment options, updated Medicaid policies, and public health recommendations. The State Department of Health had never looked at hepatitis C quite like this. The EPI profile was the first time that we'd had an opportunity to look at hepatitis C in this level of detail, utilizing other novel databases such as death records, cancer registries, and hospital discharge data. This was also the first time that we offered a comprehensive set of data to providers in this way. The roadshow generated a great deal of discussion from providers and administrators. They did not know or understand the extent of the disease burden, and we found that many health systems were not prioritizing hepatitis C and were surprised that the burden was actually so high. An area that generated the most conversation was the public health recommendations that we had presented. Next slide, Alyssa. So what was the public health recommendations? This slide represents a high-level snapshot of what we actually presented. So the public health recommendations, as everyone on this call most likely understands, is to identify people with hepatitis, link them to care, and get them to cure. What's needed to make this priority area happen? An example of the questions we asked providers during this section of the presentation included, how do we motivate and support providers in their efforts to provide high-quality services? Who's actually responsible for paying for these services? How do we motivate communities to use prevention services? And how do we make populations aware of their insurance and how to actually use it? While we were posing these questions, we wanted the providers to recognize the importance of the full spectrum of partners needed to address hepatitis C. We needed to focus on the whole care cascade, and how do we actually do this? We talked specifically about the activities we were doing as public health, which was to build a healthcare workforce and implement recommendations that worked on improving the care cascade for hepatitis C. This was a large question that we posed to providers. How do we make a system that does not currently exist to actually exist? The providers are the gatekeepers to making this happen, and they weren't actually silent. They actually had a lot to say because we actually put data in front of them that made them realize that the burden of hepatitis C is actually so high. It's more profound than HIV, and it's not nearly as a controversial topic as STDs or HIV. Next slide, Alyssa. Okay, so what did we hear? Most providers were willing and wanting to help to test, but their fear was, what would they do if they actually found positive? They didn't feel that they actually had the capacity for the prior authorization paperwork, which is something that we heard over and over and over. Did they actually have the capacity to treat? They still had a continued bias around IDU, infectious drug users. IDU, and some providers didn't even realize that there were new treatment regimens out there. We heard multiple times that they still thought it was interferon-based. Providers were also concerned about other competing priorities and about their EMR systems and why the ease of just having the records flagged and what that would actually look like. But again, over and over, we heard competing priorities were the biggest barriers to addressing hepatitis C, especially the prior authorization process. So we asked ourselves, how could we help ease some of those barriers? Next slide, Alyssa. So again, this is all before NACCHO came out with the detailing kit. We wanted to address the provider feedback, and so we took a look at how we could make the biggest impact with the resources we had at the time. Overwhelming, we continued to hear about the prior authorization process and that it would take a full-time FTE to get the paperwork in for treatment. We found that the prior authorization process in Washington State was over 8 pages with a ton of required supporting documents. I had a conversation with some of our colleagues in San Francisco, and after that conversation, we shifted our attention to specialty pharmacies. We learned that specialty pharmacies could potentially take the burden off providers by completing the paperwork and following the client through treatment. We believe that focusing on the provider concerns would have the most impact in the quickest amount of time. Next slide, Alyssa. So the actual role of the specialty pharmacies, what I did was I sent out emails to numerous pharmacies and realized that a lot of folks were tackling this work with hepatitis C. We realized that most vendors that had community pharmacy already supported HCV services. So we started working with specialty pharmacy to learn about the roles they played in the system of care. And during this time, NACCHO released their incredible and comprehensive detailing kit. Next slide, Alyssa. So as we were working with specialty pharmacy, like CVS as an example, we had determined that the mechanism to get information out to providers was going to be a multi-pronged approach. When NACCHO came out with the detailing kit, we recognized that this was an opportunity for us to actually combine what we were already doing with specialty pharmacy and the information from the detailing kit, and that would hit all of the providers' concerns. So initially, we chose one topic area to start due to the bandwidth, but now there was an opportunity to actually get all the much needed information out to providers through the detailing kit. This would help address all the providers' concerns that were elicited from the IPA Profile Roadshow and also the concerns that we recently heard through our continued efforts to increase screening activities through our community health centers for PS 1702. Next slide, Alyssa. So this is just an example of what information that's going to be displayed on our website. It's not up yet, but hopefully in the next week or two, we'll get this all set up as one part of the dissemination plan for the detailing kit. NACCHO provided an amazing layout of the information in an easy to interact with format, as you saw in Gretchen's slides. We're going to try to mirror that just because it is so user-friendly and so easy to navigate. We'll have separate links to all of NACCHO's documents so the providers can go to each link that best meets their needs. And we don't want them to have to filter through a bunch just to get to one section. So that's why we thought that the links would be the best. When the information's up, you'll be able to find it at www.doh.wa.gov, and it'll be /HepC, so it's HEPC. On this slide that you see, the red asterisks are the documents that we actually added or edited to be Washington State specific. For example, the HCV PowerPoint for providers and our Project ECHO program was added in or edited. The rest of the documents we just pulled straight from the detailing kit from NACCHO. Next slide, Alyssa. Okay, so how are we going to advertise the detailing kit? So we are going to disseminate the products by mailing to our top 100 providers that are already testing, that are already doing a great job testing. We're going to send it out in mail with 3 parts. The first part will include the Dear Colleague letter that Gretchen had spoke about. We are going to create a website information card that just describes a little bit with the actual website and an overview on how specialty pharmacy plays an important role in this work, to let them know that specialty pharmacy actually has the ability to do all the work for them. And we're going to also send out an example of specialty pharmacy materials. Another piece of this is we're going to send an email out to about 12,000 providers within our state to promote the detailing kit resources that will be found on our website when that's up with the link. The email to the 12,000 providers will have the Dear Colleague letter that is signed by official here in the body of the email, and then the links to be able to hit our website. We get the list of the 12,000 providers by our Health Systems Quality Assurance Department, which holds all of the licenses for providers in the state of Washington. We are doing a presentation at a breakout session at the Western Forum for Migrant and Community Health in February. At that time, we'll cover the EPI for the state, new treatment regimens, NACCHO's information, and specialty pharmacy information. And then in late 2018, we're going to revisit and update our current EPI profile and head out to the community to talk to providers about detailing and hepatitis C. And then at that time, have those materials available, as Gretchen was speaking, as handing to the providers. Okay, next slide, Alyssa. Thank you. The detailing kit works towards strengthening our strategies to accomplish both our statewide HCV plan and our current federal grant deliverables. So just really quick, the PS 1702, the detailing kit is one of many strategies that we will implement to assist our department in partnering with CHCs and FQHCs in the adoption of screening activities. Our goal is to provide information to the providers that help address the barriers that they've identified for adopting screening interventions. Also, our PS 1703, the detailing kit will help assist jail health services with information to assist staff with linkage to care information and supportive services for populations impacted by HCV. And then our statewide strategic plan, information within the detailing kit will help to achieve the key activities within the plan, building a Washington healthcare workforce prepared to diagnose, care for, treat, and cure persons with HCV. Next slide, Alyssa. All right, so our next steps, we'll be evaluating the amount of web hits to the detailing kit as a starter to evaluate if this is actually working. We're going to identify an internal process to ensure we're routinely reviewing and updating the materials. We're also going to be following up with providers, as I said, going out and doing a new kind of road show with our updated EPI profile. And eventually, soon, we'll tailor this to the local health jurisdictions and also see what we can do with CBOs. The local health jurisdictions make sense for two reasons. One, that they play a critical role in reporting mechanisms for HCV, and they already have pre-existing relationships with the providers. And two, our legislative appropriations for 2017 were made available for several local health jurisdictions to prioritize hepatitis surveillance and case interventions and activities. So if this work provides successful, we are hoping that we can utilize a similar model for other disease profiles within our section, like HIV, STDs, et cetera. Next slide. And thank you so much. There's just my contact information and also John Stockton, the Adult Viral Hepatitis Prevention Coordinator. And again, thank you, Alyssa and NASTAD, for allowing me to present.
Thank you so much, Nicole, for sharing all the things you've been doing and are planning to do. I'm really excited to hear how emailing 12,000 provider goes with this information and the response you receive from them, so keep us posted. And now we're going to turn it over to Jessie Schwartz, who's going to share about the work she's doing in New York City around detailing. New York City has been doing public health detailing for a number of years now on a variety of public health issues, and has a great resource page for detailing on those topics, and has also developed a complementary, or I think it was a little bit before the NACCHO detailing kit resource bank as well that we'll share. So Jessie's going to share about those efforts and what's working in New York City and the resources they've developed. So I'll turn it over to you, Jessie.
Hey, thank you, Alyssa. Can you hear me okay?
Yeah.
Okay, great. Thanks so much, Alyssa, Gretchen, and Nicole for your presentations. I already learned quite a bit about the broader issues associated with detailing. My name's Jessie Schwartz. I'm the clinical coordinator here at the Health Department in New York City, and I'm going to talk about just some more practical experiences we had with public health detailing here. At the time, we didn't really call these campaigns public health detailing, although they have the core components of what was described today. We would do a brief structured presentation, identify targeted sites and providers, and have kits or leave behinds that we brought with us. So I can move on to the next slide, Alyssa. Outline of the presentation. I'm just going to discuss a little bit of the context in New York City at the time, and then our visits to hospitals, which were distinct from the visits we had with federally qualified health centers, and then just some overall lessons learned. Next slide. So, as many of you probably already know, New York is a large and diverse city. It's racially, ethnically, and economically diverse. It has an estimated hepatitis C prevalence of around 2.4%, which is considered fairly high for a high-income country. In addition, New York City has a sizable immigrant population. Nearly 4 out of every 10 New York City residents were born outside of the United States. 1 in 5 New Yorkers live below the federal poverty level, and 26% have public health insurance coverage. And there's at least 40 acute care hospitals and 34 FQHCs or lookalikes in New York City. And I'm just giving you this background because of the diversity and the high population density, we really had the opportunity through this experience to interact with many different types of hospitals, health systems, and providers, from small standalone hospitals to large FQHCs and academic medical centers. Next slide. A little more about the context. Our program, the Viral Hepatitis Program, had few resources for a citywide public health detailing campaign. I think a lot of the evidence that's come out of New York City for public health detailing has been related to other campaigns such as smoking cessation, diabetes, I think was another one, management. But because of changes that were happening at the time in New York City and the local Hep C landscape, leadership in our program thought it was important. We engaged in some additional outreach. First, New York State had just passed a hepatitis C testing law that required providers to make the offer of a Hep C test to all patients born between 1945 and 1965. And second, as everyone probably already knows, in late 2013, new direct-acting antivirals were released that greatly increased the effectiveness of Hep C treatments. From the beginning, the goal from our program's perspective was not just to increase provider knowledge, but to have a concrete impact on their behaviors. So with this in mind, from 2014 through 2016, at least one person from our program was able to visit 32 acute care hospitals and 6 FQHCs in New York City. Also, this picture on the slide is a picture of the hepatitis C screening and linkage to care toolkit that Alyssa referred to. Although there was some printing costs associated with this, it was actually developed by a fellow at the health department who needed a project for part of her fellowship. So she developed this whole toolkit, and after doing so, she actually went on to specialize in GI and hepatology. Next slide, please. Okay. So a little bit about how we organize these visits. They were organized by Viral Hepatitis Program staff. In particular, we have a program planner, Ryan Duerme, who really took the lead on this coordination. And he worked with administrative staff from the hospitals. It was really the planning and not the visits themselves that took the most time, as you're all probably aware. It took approximately 1 to 2 months to schedule one of these visits. What really helped facilitate the planning was identifying early on a provider at the hospital or health center who took a lead role on hepatitis C in that institution, and also, even more importantly, the administrative point person who could really facilitate the process. To ensure that key staff were present for the meeting, we invited representatives from internal medicine, ambulatory care, HIV and infectious disease, gastroenterology, psychiatry, drug treatment, laboratory, information technology, and other leadership if they were interested in attending. Our program also developed a baseline hepatitis C survey that staff were asked to complete prior to our visit, so we'd have some baseline information with us. And these visits had a fairly narrow focus. We were focused on increasing baby boomer birth cohort screening and implementing reflex testing. Next slide. This is just an example of how we tracked the meeting planning, which, like I said, took a lot of time. This, once again, was created by Ryan Duerme in our program. And it just started with a list of hospitals that we wanted to target. And then Slowly, information was added in over time, and he used color coding so anyone could go in and look and see how they completed their survey. We added visit notes for other people who wanted to look back. Because there were so many hospitals, different people from our program would go to the visits, although often our medical director at the time, Fabienne Larocque, did try and attend most of the visits that she was able to attend. So you can see we have a spot where we have the administrative point person who helps coordinate the visits from the hospital's perspective and then identified other doctors who were interested. And it's actually more expensive, but I just wanted to give you an idea of how much tracking and planning was involved. Next slide, please. This is the general meeting structure for the visits. We would first have a round of introductions where we ask people to introduce themselves and describe their role at the hospital, as well as any hepatitis C related experience or projects they were working on. Someone from our program, usually the medical director, then delivered a brief structured presentation. I just put some examples of the slides that we used. You can see we tried to use as much local and New York City surveillance data as we could to make the presentation relevant to the population served by the institution we are visiting. We would then engage in a discussion around current practices and opportunities within the hospital. Finally, we would ask the hospitals if they could identify ways to increase screening or reflex testing and have some discussion around these opportunities. We also had leave behinds. We had the toolkits, and we had a lot of, I think what hospitals were really interested in oftentimes were our patient-facing materials. They didn't always have a resource for that, so we also brought along patient-facing materials. And so sometimes hospitals really didn't feel there was anything they could do. They weren't in a good place to make any changes, or they were transitioning to a new EHR and didn't want to involve themselves in any other big projects. But more often than not, they were able to generate their own solutions or ideas for how to increase screening or move to reflex testing. Next page. Next slide, sorry. So what we felt like worked from these visits was definitely having the administrative point person to help coordinate, having diverse departments within the hospital represented, very helpful. For example, when discussing reflex testing, having someone from the hospital laboratory right there with the person from primary care discussing what types of tubes they would need or different types of concrete workflow issues. It was great just to have them all at the table, and we recognized that these people didn't often meet each other. Their paths didn't cross in their day-to-day work, so it really was just an opportunity for them to, sort of reflect on what was happening and what could be improved. I think grounding the discussion in New York City specific data was also very helpful. We have a map, and hospitals would look and locate themselves on the map and see they were in a high prevalence area. Oftentimes they already knew that, but it was helpful to see data from around the city. The survey was very helpful. That part was often challenging to get, but having some baseline information, I think it was in the tracking spreadsheet, even on the previous slide, we were able to say, did they currently do reflex testing? If they were doing reflex testing, then we would focus more on the birth cohort screening. Things like that was good to have a little bit of information, what lab they used. We could look up what tubes were required, this sort of concrete information. Also, I think what was really important was learning from hospitals and practitioners. Like in the reflex testing example, we went to a hospital that, which was a problem we encountered at many hospitals, that they did some of their testing in-house. So their antibody testing would be done in-house, but they would send out samples for the viral testing. So hospitals had already come up with their own very creative solutions to implement reflex testing that we were then able to share with other hospitals. Some would freeze a tube when they did the antibody test and then send it out, or other types of sort of creative solutions to incorporate reflex testing into their existing workflow. Also, for us, having a clear vision and objective, so we knew we wanted to focus on birth cohort screening and reflex testing, and that made it very simple. Often, I think, like Nicole referred to, they did have other issues, so we weren't always able to provide great detailing on these other issues, but it did help to be very, to have a very narrow focus. And also identifying hepatitis C provider champions. So having one person who really cared about this issue and who was willing to meet with us and drive changes in their hospital. Next slide. Here's some of the challenges with a hospital visit. There was a short time for meetings, and that precluded us having more in-depth discussions. Sometimes we would get into a really great conversation and then the meeting would end, and that was problematic sometimes because the providers did have a lot to share with us. Also, most hospitals didn't have a dedicated team for hepatitis C, so it took coordination between many departments, often drug treatment, GI, primary care. So there wasn't one place where hepatitis C sat within the hospital. It was often treated in various different places, and that sometimes made coordination difficult. In the long term, we did find it was very difficult to sustain their engagement. If we identified a solution that was relatively easy to do in a short time period, we had more success, but longer term projects were more challenging to sustain engagement on. Also, hospitals have competing priorities. This is very specific to New York State, but we're going through a massive Medicaid reform or redesign in the state, and so a lot of hospital resources were being put towards those projects, and they didn't always see that they had the time to do any major changes around hepatitis C, which also, isn't included in any of the meaningful use or quality sort of initiatives that were going on in the state at the time. Medication prior authorization denials. I mean, this is something we heard from providers everywhere, and which was referred to earlier, which is, why am I going to screen and identify positives if I can't treat them? And from their perspective, this really was a barrier to increasing their testing and linkage to care. For some hospitals that do their testing in-house, which is fairly common in New York City, I don't know how common it is in other jurisdictions, but we were unable to help hospitals quantify the fiscal impact of implementing reflex testing in their facilities. And so people would say, well, it's very expensive, and we do have a fair amount of uninsured patients. We don't, we're hesitant to do this. We don't really understand what the financial impact would be. So that was a barrier oftentimes for that internal hospital laboratories. Next slide, please. I'll talk a little next about our visits with federally qualified health centers, which occurred mostly in 2015. These were visits, I actually attended all of these visits. They were organized by our staff here, and program managers or physicians at the federally qualified health centers. There were fewer, I found, administrative staff at the FQHCs to support the planning process as compared to the hospitals. That might differ by jurisdiction as well. So the planning still took 1 to 2 months. One visit took 3 months actually to plan. We invited quality improvement, program managers, medical providers, generally from ID, HIV, and primary care, IT, and nursing staff. We reviewed surveillance data from the sites prior to the meeting. And once again, the focus was still on baby boomer birth cohort screening and reflex testing. Next slide. So this is an example of like a little report I would pull together prior to going to the FQHC. I would, let them know how many antibody positive reports we had from them in a calendar year, what labs it looked like they were using, how many individuals appeared to have reflex testing, how many appeared to have a confirmatory test, and for a certain time period, how many appeared to have current hepatitis C infections, so sort of their past year caseload or an approximation of it. And this is, we get very messy data, so this was a guess, an educated guess based on our surveillance reports, and it was generally, seemed fairly close to what they believed they had at their health centers, but we weren't always able to completely validate it with them. but it was helpful for starting the conversation. Next slide, please. Also, prior to going to a health center, I would try it, because New York City is so diverse and has so many neighborhoods that I haven't even been to all of them. I would try and do a little bit of research about what was going on in the community and about the health center itself. So this is an example of a community health needs assessment, which I think are done, I think it was part of the Affordable Care Act legislation that each hospital, I think if it's a not-for-profit hospital, has to create these community health needs assessments every year or two. I found some more information on it from the Association of State and Territorial Health Officials if anyone's interested, but really what it was useful for was identifying the health needs of the community and the work that needed to be done in the community to improve the health of individuals living there. Hepatitis C never showed up as a primary health condition for the community, but you did get to learn a lot. If it was a lot of drug use or mental health disorders, it often coincided with a high prevalence of hepatitis C infection in the community. And then also to the right of it, you'll see the health center profile from the UDS system. And that was helpful just in identifying, did they have a lot of uninsured patients? If they have a lot of uninsured patients, then you better come with resources about pharmaceutical patient assistance programs. Do they have a high number of Medicaid patients? You know, if they do, then you want to come prepared with a lot of information about the Medicaid prior authorization process. So we would try and read up as much as we could prior to the visit to understand the community and the demographics of the health center. Also, which is probably unique to New York City, but some health centers saw a very high proportion of foreign-born patients for which the risk factor or profiles for hepatitis C might be different. In other countries, you still can acquire hep C from a blood transfusion or other medical exposures. So we kept that in mind in the visits as well. Next slide, please. So what worked was, in a smaller setting, we were able to roll up our sleeves and really get things done. Sometimes the IT person would look at their EHR with me and show me some templates or prompts they could put up for providers, and we would work together to identify solutions. There was less hierarchy and the change could happen rapidly. Often they were already engaged in innovative approaches to treating Hep C, and we were able to build on those or to share their interventions with other health centers. We offered local resources and opportunities to them, and we had patient materials available, which everyone was interested in. Also, the site-specific data was interesting for them. Not all of them had the capacity to pull those reports. Next slide, please. Challenges, technical difficulties for the presentation. I learned early on I had to bring color slides with me in case there was no projector capability. Provider burnout and turnover was an issue, so sometimes I would connect with someone and they would leave and I had to identify a new person. They had many competing priorities, such as meaningful use, other data reports they had to submit. Fewer support staff, like I mentioned earlier. Their internal IT capability varied. And in particular, medication prior authorization denials, which were even harder sometimes, at least at that time, to get approved than private insurance or Medicare, were a big barrier for these facilities. Next slide, please. So this is our overall lessons learned, that administrative program, nursing, and support staff are a crucial part of the quality improvement team. Plan well, do your research. If you can collect the survey, that's great to make the most of your visit. Be flexible. If you go in wanting to talk about something, but they have something else they need to share with you, you really have to listen and allow them to direct the conversation. Keep presentations brief and specific. I don't know, my background is actually, I worked as a nurse for many years, and we had to do all these 12-step program things, and they used to tell us in Al-Anon, wait, so that's why am I talking? Oftentimes people, just getting them in a room, giving them some information, they're able to generate their own solutions and talk things through with you, and often it's good to listen and learn from them. other than, always being the one doing the talking. Local data is the best data. Whatever local information you can get and provide to them is helpful. If you reach out to a lab or Quest or whoever you have that could maybe provide you with data, if you don't have surveillance data, that might be helpful. Follow up the next business day just with a thank you, rehash what was discussed, a few follow-up items. That's helpful just to stay in touch with them. Having clear objectives. Our very narrow focus made these visits easier because we weren't throwing too much at people. And then also responding to any requests you might receive and making yourself available to support their projects if they need assistance with data for grant writing or other types of things. We always made ourselves available as a resource to them. Okay, and that's all for today. Here's my contact information on the next slide. And thanks again for everyone at NASTAD and Alyssa for having me.
Thanks so much, Jessie, for telling us all about New York City's public health detailing efforts, particularly around the challenges and what works. That's really helpful to know when people are thinking about how they could start to implement this in their programming. So we're going to open up to questions, and I am mindful that we have about 7 minutes for questions, so feel free to include those in the chat box. We've received none so far, so I'm going to take the narrative prerogative and ask the first one. But I know, Jessie, in previous conversations and in this presentation, you focused specifically on hospitals and FQHCs, and I'm curious if public health detailing works better in some settings than others, and any lessons you have from trying to do this in other settings beyond the ones you've talked about already.
Hi, yeah, I think I may have mentioned before, although it wasn't included in this presentation, that we attempted to do some public health detailing with methadone treatment centers in New York City, and it wasn't as successful. We went through the same stages of planning and having a presentation, and at the visits, it was really hard to get providers to come. When they did come, they were very overwhelmed. They often, felt that their population had so many needs that hepatitis C just wasn't a priority for them, or perhaps also for their patients. And, we just weren't able to be successful. It's something I've wanted to take up again, how to make this type of detailing relevant in different settings, but I think it seemed to work really the best with hospitals, and well, it also worked very well with FQHCs, although it depended on what was going on at the time with FQHC. But with the smaller drug treatment centers, we really faced a lot of difficulties, a lot of resistance.
Great, thank you for that, Jessie. And I think that's really helpful context as different programs are looking at ways to reach those settings and also opportunities to integrate this into their work, just recognizing that this is a strategy that works well in a lot of ways, but isn't going to be the solution for every partner, and might need to be modified and adapted depending on who you're engaging. So, and I also just wanted, since no other questions have come in, to thank all of our speakers today. All those presentations were really thorough and helpful in both telling us more about public health detailing, but really focusing on what resources are available and how states and cities can use those resources or modify them in the work that they're doing. And I think one of the key messages and takeaways I received from these presentations is just that the importance of engaging a variety of partners in this work, and the role that public health can play, particularly as we start to look at elimination and think about how we reach people who have not yet been diagnosed with living with hepatitis. I think it's important to think about who we should be engaging and how we can be supporting them in our work through things like provider education, and detailing seems to be a great approach to doing that. So I wanted to open it up, because we have a few more minutes, to see if any of the speakers had any final key messages or takeaway points or reflections that they wanted to leave the audience with today.
This is Gretchen, and Alyssa, I think it's really just echoing something that you just said, which is really about tailoring this strategy, whether it be the particular message, that's being delivered or how the information is compiled, and really tailoring the strategy to make it work for your jurisdiction. So thinking about, these are all very valuable resources, and they can be, speaking from the standpoint of the NACCHO detailing kit, can be implemented via the one-on-one provider visits, but they're also just in general helpful resources to deliver in a larger setting, or, as we heard from Nicole, to make available online. And so for those that are not currently engaged in detailing, or if it seems potentially overwhelming from a resource standpoint, thinking about where you can start using what's currently available and then building from there.
Great, thanks, Gretchen. Nicole and Jesse, did you want to share any last minute takeaways or reflections before we wrap up?
Sure, this is Nicole. Do you hear feedback?
No, you sound good.
Oh, okay. So I was just thinking what Jesse had kind of said is trying to, how it is difficult to try to get providers to actually, take a little bit of their time from all the other things that they have going on and all the other competing priorities. What we did when we did the Epi Roadshow in 2016 is we created CME events. And that really helped to, want to make that providers actually wanted to attend and to be able to do that. So we're looking at potentially doing something like that again to see how we could do a CME event that makes it more valuable to come and then hear the message and then get it. So that's just another thing that I wanted to add.
Thanks, Nicole. And I know just in response to the webinar announcement, we heard back from a few different community-based organizations who are going more that route because detailing and those visits directly to providers is not as realistic for their bandwidth, but a lot of the information within these detailing kits are resources that they're included in, like day-long or luncheons for CMEs with providers. So just like has been said, I think, by all of you, and Gretchen just emphasized that it's kind of like the harm reduction approach to provider education, where you can take however much is most relevant and useful to the work that you're doing and go from there. So I'm just going to be mindful of time, and we're just at the end of the hour. So I want to thank all of our speakers for presenting and sharing about the great work you're doing in your programs, and thank everyone for joining us today. And just let you know that the hepatitis testing has these quarterly webinars, and if there's a topic that you're interested in learning more on related to hepatitis testing, or if there's work that you want to present on, you can always reach out to me. My contact information is on this final slide, as well as the link to the Hepatitis Testing Partnership page. So thank you, everyone, and I hope you have a great day.